Rawalpindi. Then Professor Najam Haider from Children's Hospital Lahore. Then Colonel Irfan sir, please join us. Colonel Irfan is pioneer in EP at AFIC, and we have lots of regards for him. Colonel Intisar, please join us, sir. Sir is pediatric cardiac surgeon at AFIC. And Dr. Abdur Razak, please join us. Dr. Abdur Razak, thank you so much for coming from Faisalabad. He just hosted a very good pediatric cardiology annual symposium very effectively, and he hosted us very well. Thank you so much. So with your permission, sir, should I start? So first of all, in our session, आप आगे आगे आ जाएं please. आगे आ जाएं. So first of all, I would like to invite my senior and head of department, Professor Brigadier Khurram Akhtar. Sir is going to talk about PDA stenting, breaking barriers. And truly, he broke many barriers in PDA stenting, and we are very thankful, sir, for teaching always for PDA stenting. Brigadier Khurram.
Bismillahirrahmanirrahim. So the principal indications for ductal stenting is to keep the ductus reliably patent as a secure source of pulmonary blood flow in cyanotic heart diseases. And the other indication for ductal stenting is when you want to retrain the left ventricle in patients with simple TGA who present late and have and their left ventricle has involuted. This procedure was first carried out by Gibbs in 1992. So neonates with duct-dependent blood flow require a stable source of pulmonary blood flow as their initial palliative procedure. Initially, this was being done by a BT shunt, and now we have this ductal stenting as the procedure of choice. The data from large multi-center studies, PDA stenting has not only emerged as an acceptable alternative to the BT shunt, but it has now become the preferred method of in many circumstances. And with today's generation of coronary stents, which have better profile, flexibility, trackability, so stenting is a very good option. It stands in the class 2 alpha and 2B in AHA guidelines. Ductal stenting is a less morbid method of left ventricular training when you have the transposition of great vessels. One, that it does not damage the main pulmonary artery. And the second is that the new aortic valve, it prevents it from developing regurgitation. So in transpositions, we sometimes have a duct which is almost closed. So we can actually we create a duct and then stent it in order to retrain the left ventricle. Now, in order to stent a duct, one must be cognizant of ductal anatomy, ductal origin, the tortuosity index. And the PDA and cyanotic congenital heart diseases tends to be elongated tubular structure with having more than one curves. And the morphological variation of PDA and cyanotic congenital heart disease can be limitless, with most bizarre being very elongated tortuous having acute bends in different planes. So as you can see, this is a type C variety coming off from the undersurface of the arch in patients with CTGA with pulmonary atresia. So relatively short straight ducts arise from the proximal descending aorta and inserting into the dome. These are easier ducts to stent. The ones with pulmonary atresia, intact ventricular septum, critical PS, tricuspid atresia, Epstein anomalies, and transpositions. So as you can see, this is a relatively easier duct that was stented with Zions 4 millimeter by 12 millimeter wide stent. Athar has made this tortuosity index, which is now published, type 1, type 2, and type 3. Type 1, where type 1 is relatively straight duct, and type 3 has multiple complex turns on the ductus. So this is ductal morphology. You can actually wire the duct, and then you can measure the length of the stent. It's better to wire because it actually straightens out the duct when you have tortuous ducts. Another classification based on the geography of the ductal origin from short and straight ductus originating from the descending aorta to the type E where you have bilateral ducti. So this is one such duct which is coming from the undersurface of the arch. This is a type C. This is type D, a duct originating from the innominate vessel. And it looks almost like a BT shunt. We had this 60 patients over the last 1 year where we found out that the maximum number of patients were tricuspid atresias and TOF with pulmonary atresias that we stented. Our success rate was almost 90%, and in-hospital mortality was 7%. Now, in order to stent duct, we had patients ranging from 2 days to 3 years. Male, female gender was almost equal. And a maximum number of cases were performed in the first week of life. 4 French and 5 French catheters were used. Duct's stent size varied 3.5 to 4.5 millimeters. For patients weighing 3 to 4 kilograms, we chose a 4 millimeter diameter stent, and for those weighing between 4 and 5, we took a 4.5 millimeter stent. For patients under 3, we took 3.5, and below 2.5, it is advised not to do so. Generally, we start our catheter work with a guide wire, and often at times this wire allows us to cross the duct, and then this is recrossed with a BMW wire. You can actually measure the length of the lesion by the end of the BMW wires, which have this radiopaque tip. Various types of wires that can be used. Access femoral artery was the major access. This is the sheathless entry, where we are putting a 5 French guide catheter in order to deploy the stent by using a balloon so that it is tapered and that we can enter into the various approaches that were employed, that can be employed are the right subclavian artery approach and the left subclavian artery. The implanted stent must not create stenosis. Rule number 2 is not to jail a major branch vessel or vessels to major areas, and not to implant the stent that knowingly results in aggressive tissue reaction. A biplane catheter lab is required with a freeze frame capability. The specific stent and balloon must be available. A large inventory of miscellaneous diagnostic catheters, wires, special torques, deflectors. So we can take the retrograde versus the prograde approach. Easier to handle pulmonary atresia with intact ventricular septum when the duct is in the usual position. So ductal morphology, its origin from the aorta and angle subtended are the things that we do a CT scan before we venture into doing a ductal stenting procedure. The ductal shape, tortuosity, site of insertion at the pulmonary end, narrowest diameter of the duct, and its relation with respect to trachea and bony structures. Presence or absence of branch pulmonary stenosis and confluence of pulmonary arteries, and presence of additional pulmonary flow. Exclusion criteria for stenting is complex ductal morphology, insufficiently constricted ducts, pre-existing branch stenosis. The origin of the ductus from the aorta determines whether the approach should be antegrade or transvenous method, so it's actually the origin of the duct that guides us which approach should be taken. In the majority of our cases, PDA stenting could be accomplished retrograde from the femoral artery. We used a 4 French Judkins right catheter or a cut pigtail and used an 014 coronary guide wire. Appropriate size and length of the coronary stent was then chosen and deployed. Most of the patients were neonates, very young infants who were initially on Prostin, and a small number of patients who cannot tolerate a closure of this Prostin few hours before we generally continue this infusion. The procedures were performed under general anesthesia, and hemodynamics and blood chemistry and metabolic were looked after by the anesthetists. For the procedure itself, one femoral artery is cannulated with 5 French sheet, and one vein is accessed with a 5 or 6 French sheet. Heparin is used. Baseline measurements, arterial blood gases are used. So the ducts which are seen in pulmonary atresia, critical PS, tricuspid atresia, these are type A ducts. So this is a pulmonary atresia with intact ventricular septum. As you can see, this duct is relatively easier to cross, and it was crossed with an 035 to remove guide wire using a 4 French Judkins right, and later on, Axlemus 4.5 by 16 millimeter stent was deployed. We had a post-procedure saturations of 90%. For transposed great vessels, this is another easier way of putting a duct the retrograde approach, because these ducts are usually at the usual location. And as you can see, we have been successful in deploying the ducts. Tricuspid atresia, pulmonary atresia with narrow ducts. Almost the same thing. It's easier to cross, and then followed by a ductal stent implant. This was pulmonary atresia, tricuspid atresia intact with a 4-month-old baby, where a similarly stent has been implanted. This is an axillary approach in a patient with TOF with hypoplastic central pulmonary arteries. The patients who have TOF with pulmonary atresia, the ducts are more complex, and they usually rise from the underside of the arch, opposite the origin of the left subclavian artery. This type of vertical ductus generally is not amenable to stenting via the retrograde approach. The femoral artery route, as it's very difficult to engage. So in such cases, an antegrade transvenous or an axillary approach is generally taken. As you can see, in this case, we took the axillary approach, and we were able to stent this duct from the axillary artery. And this is the post-procedure. So non-confluent pulmonary arteries can also be stented, as in a left pulmonary artery was stented with a duct with a stent, whereas those on the right side collaterals were either stented or ballooned. We had incidences of in-stent thrombosis. As you can see, there are in-stent thrombosis. Guide wire was passed, and then it was ballooned. We also had procedure failures. This procedure could not be completed as the patient became unwell. Multiple approaches, including the axillary approach, was applied in this case. We have been stenting patients who had corrected transpositions. We have had incidences where we jailed vessels. So in this kind of situation, we passed a wire through one of the struts and then ballooned it. This is ballooning the strut, which was actually draining the left pulmonary artery. We had stent-in-stent deployment was 2 stents deployed following the first stent migration. So we had a stent which migrated distally into the left pulmonary artery. As you can see that the stent is there is a stent which is lying there. So we had to deploy another stent. So we have ductus arteriosus arising from the subclavian artery. These are the least common type of ducts where we had to stent them. So heparin, thrombolytic therapy, antiplatelet agents in a stable, hemodynamically stable patient. They are transferred to ICU where they are kept ventilated for 12 hours. It is common to have a high near normal oxygen sats in the first 72 hours. Clinically, severe heart failure from overshunting is uncommon. And then we use heparin infusion to keep the duct patent. We had complications like stent migration, thrombosis, pulmonary edema, pulmonary hypertension very rarely, and branch pulmonary stenosis. Ductal spasm, embolization, acute stent thrombosis was the complications that are likely to be expected. That's my pride, and thank you all.
Thank you, Sir Khurram. Do you have any question about PDA stenting? Yes, please. Mike ne. Mike, please.
Sir, I must say it was an excellent talk. You covered almost all kind of PDAs. Only thing I want to mention is about the prostin. We don't have a easy access to inject IV prostin. But last week at Lahore, I did a PDA stenting. It was 6 days old baby, and somehow the parents were like laying and rich. They arranged around 10 vials of prostin from some black market. And it was so easy standing. PD was like this big, only end was constricted. I stopped the prostin for 3 hours. So, I mean, if you have prostin, the PDA standing is like pretty much easier. And it's available in the black market. He told me some address in the Lahore. I have got some like 9, 10 vials he donated us for poor patients. So, I mean, so one vial was around 8,500. Not a big deal. One vial lasted for around 12 hours. So, I mean, we can have some backup in the difficult duct when duct went to the spasm or, yeah.
Okay, thank you. Now I would like to invite Brigadier Mehboob Sultan. He will talk about RVOT stenting tips and tricks. Welcome, Brigadier Mehboob Sultan.
Bismillah ar-Rahman ar-Rahim. Thank you, Sir Amjad, sir, for giving me this opportunity to present my talk in this forum. To start with, we have got a great match today, so a lot of prayers are needed, and a lot of these expressions are needed from today's match. And hopefully, maybe on the other side, we may have a lot of cardiac stents after the match. So with these words, I will start my talk. Talk is about the RVOT stenting. So it's a kind of a new procedure as a palliation for the tetralogy of fellow patients. We all know about the tetralogy of fellow. Only thing I want to mention is if you don't treat them, it has got the untreated, very high mortality. 10-year survival is only 24%. And if you look at this management algorithm, so many patients, almost 90% or plus, they all end up with primary surgical repair. They are suitable candidates for complete repair. But there is some group, small subgroup, which have got small pulmonary arteries or other comorbids. I will mention in next slides. They are not candidate for complete repair. So here we have to offer them some kind of palliative procedure. And it's still controversial, what palliative procedure is the best for these small, young infant with tetralogy of Fallot who are having spells or small pulmonary arteries or unfavorable anatomy, abnormal coronaries, and so on. So in these patients, traditionally we are putting PT shunt, that is aortopulmonary shunts for the last around 8 decades. Other surgical options are also tried. But if you look at this data is from Society of Thoracic Cardiac Surgeons. It's a pretty big data, actually.
So what they did was they operated 3,059 patients with tautology of fellow from 2002 and till 2007. And if you see the mortality over here, especially here, the mortality for neonatal TOF repair was around 8%, pretty high. And for BT shunt, even the mortality was 6.2%. In contrast, the mortality was around 1% in patient with 3 to 6 months, 6 to 12 months. So, I mean, the BT shunt is not free of complication, very high mortality, overflooding, stenosis, occlusion, and so on. And few procedures we were doing for these patients like PDA standing, but then we need a PDA to be open. And then ballooning of pulmonary valve. I must say we are doing it, but this is certainly unpredictable results. So all these palliative procedures are kind of lacking in some of the characters of the ideal palliation. So nowadays the RVOT stent is gaining some popularity as a palliative procedure in these tautology of patients because it allows physiological flow into the pulmonary arteries. That is antegrade flow from the RV into pulmonary arteries, which results in symmetric growth of branch pulmonary. This is symmetric growth is very important because of antegrade flow. Certainly less traumatic, and it avoids the complication of BT shunt. So here you can see the slender pulmonary arteries which was stented RVOT. I will show you the image. So this is Toronto experience, pretty small, only 11 patients they did RVOT stenting, but there was no procedural complications. Then this is Birmingham Children's Hospital's experience of 10 years from 2005 to 2014. I was part of the few of the patient back in 2014. So the data was about 72 patients where they had RVOT stent implantation. Median age was around 2 months. So mortality was only 1. So 1.4% mortality, 1.4% emergency surgery. SATs certainly increased. So this was a person, I mean, he was like my mentor for these procedures, Dr. Oliver Stumper from Children's Hospital, Birmingham. Then we started back in 2016, RVOT stenting in AFIC, and we are also doing it at Army Cardiac Center, Lahore. So I think we have done more than 50 cases with various indication and acceptable success. Just a couple of slides. So this was a 20-year-old girl with a severe RVOT obstruction and small branch pulmonary arteries. She had BT shunt twice, which were blocked. So we put a stent, and then she needed actually 2 stents. And this is the case I did around 2-3 months back at Army Cardiac Center, Lahore. He was 4 months old, Down syndrome, 4 kilo, having refractory spells. So we had to put a stent in. So he did very well after the stenting. And these are generally indication of RVOT. RVOT stenting indications are same for any other palliative procedure like BT shunt for tautology patients. Now coming on to actual tips and tricks, the procedural technique is pretty simple. You need access, you need to deploy the stent, and then you evaluate after the stent. But the preoperative imaging is very important. You need a good echo before putting the stent. You need subcostal imaging, parasternal short axis, and you need to measure the length and diameter of the infundibulum, apart from other features. And it will be also used during the stent deployment. Access-wise, usually it's right femoral vein. Interjugular vein can be used in low birth neonates only. We need biplane angiography preferably. RV angiogram is usually done with the help of Gensini or NIH. The view is RO 30, cranial 20, and LO 90. So these 3 are the RV angiograms which you did. Up on these are the RO views, and this is true lateral view. And then we need to put a long sheath. So this long sheath is very important. Generally, we don't have access to these long sheaths somehow. But we are arranging some flexor sheaths, some radial sheaths which are 23 centimeter. If we don't have, then we can use the short guide catheter. You can cut the guide and make it shorter, or Mullins. So you need to have some long sheath to just take the stent in. Rationale behind the long sheath is this: it's less traumatic. It allows smooth stent delivery, and then it facilitates balloon and wire removal as well. RVOT is generally crossed with JR catheter with Jerome wire. And then once wire is in the RPA, you advance the long sheet into RPA. So this wire placement is a key. You need a very good wire placement deep in the RPA. And then we use the wires according to stent. If you're using the coronary stent, you need 0.014, otherwise as they suggest. Usually it's a one-man job. I mean, you stabilize the stent with the left hand and inflate with the right hand. So otherwise you can use the help of assistants, but you need to just push the stent in the RVOT rather to just pull it during the inflation. Is it advisable to dilate the pulmonary valve with the same balloon? Yes, maybe. But sometimes I just leave the pulmonary stenosis, valve stenosis, just to avoid the pulmonary overcirculation. And then deflate the balloon, resheath within the long sheath, stabilize the stent. So sheath should be ideally inside the stent before you start retrieving the balloon. Then perform the angio and echo for any proximal uncovered area, effusion, tricuspid regurgitation. Observe for a few minutes. Stent selection is dependent. It's on the clinical context. What's the age and weight and all the other things, whether it needs a further dilatation or not. Usually we use the coronary stents, which are 3 to 5 millimeter. We don't have availability of the bare metal nowadays, so we are using the drug-eluting stents or renal or biliary stents. Sometimes we use the vascular stents. Ventilous stents, which are covered stents, which we are using for coarctation, there also seems promising because then they can avoid the damage to the myocardium. Biodegradable stent, we haven't used it. So the advantage of RVOT stent is it allows greater rise of oxygen saturation. And then there is better and more constant and symmetric growth of branch pulmonary arteries. So this paper is from Indonesia, recently published. So they did RVOT stenting in adult patient and pediatric patients. So you see the oxygen saturation was significantly higher after the stenting. And then there's a branch pulmonary artery growth after 4 months of stenting. Another one after 5 months. And this was Agile child at Birmingham Children. So you see there's definite symmetric growth of branch pulmonary arteries. The challenge is the procedure is, I must say, it's a technically difficult procedure with some kind of significant learning curve. And then there is issues with the re-intervention. Potential risk can be many, but I would focus on just a surgical one. What happened when you remove the stent from the RVOT at the time of total correction. So this was published in 2015 from Germany. So they operated on 27 patients after the RVOT stents. And then 20 patients, the stents were completely removed. So there was no issue. In 7 cases, they have to put the RV2PA conduit. And some part of the stent was left in part in 5 patients. And there was no perioperative or perioperative deaths. To conclude, I would say that RVOT stenting is technically feasible, well tolerated, and effective palliation in young and critical patients with tetralogy. Because it allows pulsatile antegrade pulmonary flow and results in immediate increase in oxygen saturation and symmetric growth of pulmonary arteries. Meticulous echo imaging and use of long sheath is key to the success, and stent selection is generally dependent upon clinical context. Thank you very much.
Thank you, Brigadier Mehboob Sultan.
Sir, may I ask a question?
Ji,
sir?
please.
Sir, first of all, I would like to comment that it's an excellent presentation and, of course, an excellent task that you're doing in Army Cardiac Center. Being a surgeon, I must confess that you are providing a great rescue not only to that sick child, but also to a surgeon as well, because we know the problems that are associated with PT shunt, and you have briefly mentioned those as well. My question is that once the patient goes in increased pulmonary blood flow, I mean, you must have seen some cases. So how do you really manage them post-stenting? Is there any special, and how many cases you have seen really?
It's a very good question and very pertinent as well. Personally speaking, I don't know about other operators, but I leave the pulmonary valve stenosis. So I stent the RVOT, I leave the pulmonary stenosis, so I leave some degree of RVOT obstruction intentionally. If you want to do the pulmonary ballooning, you can always come back after 2-3 weeks, 2-3 months, you can always balloon it. So this one maneuver definitely results in prevention of pulmonary overcirculation. But then patient have developed pulmonary overcirculation, then we have to keep them ventilated for like 24 to 48 hours, keep the diuretics, ACE inhibitors, and manage them like a pulmonary overcirculation. But most of them, they do very well after 24 to 48 hours.
I have just a comment. Congenital heart, basically we can't survive without a surgeon. Yes. Important thing is that in both stenting in PDA and also in the RVOT, tetralogy and permeatasia is a complex disease. And the permivasculature is very important for the success of key, especially for regarding stenting. The maneuver that we are doing, the stenting basically palliate the patient, give the rescue from the emergency. It's not the 100% curable for that or 100% treatable disease. Otherwise, we have to go for the surgery. It's just a palliation, and we give the rescue to the patient so that later on, after 4 or 5 months, surgery is the best option for both of these cases.
Sir, thank you for an excellent talk. Sir, you mentioned about coronary stents in neonates. Yeah. So, beyond neonatal age, what are the stents that you use, or what's the efficacy of coronary stents beyond the neonatal age?
After neonatal age, coronary stents is almost kind of useless. It's because we are having stents which are available at the size of maximum 4.5. We don't have even 5 millimeter coronary stents. I don't know about the other centers, but at the ACC or FIC, we don't have a 5 millimeter coronary stent. So beyond neonate, I don't think there is any room for coronary stent in place of in the RVOT. Then there are option of using biliary stents, renal stents, vascular stents. I mean, there are stents which we can use, but there are definitely issues with their availability and their length and diameter, etc. But we are talking with the people who are dealing with the stents, and they have promised that they will give us the vascular stents in the near future with all the sizes, diameters, and lengths. Thank you very much.
Thank you very much, Mehbul Sultan. I would like to add that for RVOT stenting, if you want to get optimal results, the anesthesia team is very important. You must intubate the patient. As a question asked by Colonel Intisar, that there is a chance of pulmonary overcirculation. So you must be ready that the pulmonary overcirculation can happen. So you must intubate the patient. The patient should be deeply anesthetized and ventilator should be ready so that the patient can be managed effectively post-procedure. Thank you. Next, I would like to invite Dr. Maimoona Saeed, our fellow. She is talking about palliation before the sky turns dark and need of the hour. Dr. Maimoona.
Pointer? Where's the pointer? यहाँ से Bismillahirrahmanirrahim. I'm Dr. Maimoona Saeed, Fellow Pediatric Cardiology at AFIC. So my talk is on palliation before the sky turns dark in need of the hour. Case studies related to need of heart-lung transplantation in Pakistan. Palliation in congenital heart defects involves surgical procedures that aim to improve the circulation of the blood and alleviate symptoms, but do not cure the disease. The goals of palliation vary depending on the type and severity of the defect. There are 21 palliative procedures for the surgical management of congenital heart disease, which can be classified into 4 categories. Increasing pulmonary artery flow for pulmonary oligemia, like the shunt procedures. Decreasing pulmonary flow for pulmonary overcirculation, like the pulmonary banding and Norwood procedure. Enhancing intracardiac blood oxygen mixture for systemic hypoxemia, like the atrial septostomy. Other procedures including congenital mitral or aortic stenosis palliation, coarctation of aorta palliation, and hybrid palliative procedures for the hypoplastic left heart syndrome. These procedures may be used as a bridge to a more definitive repair, to allow growth and development before further interventions, or as a means of managing symptoms in patients who are not candidates for complete repair. There is a growing trend towards the use of interventional techniques with stent deployment as an alternative to surgical approach. My first case is Muhammad Irtaza, 25 years old boy with pulmonary atresia, VSD, duct-dependent pulmonary circulation with non-confluent PAs. His first palliation in the form of ductal stenting was done in April 2024 at the age of 6 months when his saturation was in 60s. This is the angiogram showing severe ductal stenosis at the LPA origin with non-confluent PAs. The second angiogram is showing 3 significant collaterals with multiple point stenosis augmenting right lung parenchyma. Here, the axillum is 4.5 into 12 mm stent being deployed at the narrowest insertion point, LPA origin. The second angiogram is showing post-deployment check angiogram with good flow in LPA. This is the CT angio 3D view showing, this is pointer works? Showing the stented PDA arising from the undersurface of the arch of the aorta and then could use as LPA. This is the descending aorta with multiple delicates, MAPCAs, collaterals arising from it and supplying the left lung. So we delineated the collaterals and stunted the duct. This improved the child saturation from 60 to 90. But then again, at 1.5 year of age, the child started desaturating. CT angio was done that showed center stent stenosis. Case was discussed with the foreign team of Boston children, which advised us to reballoon the block stent and either balloon or stented the blood supply to the right lung, existing blood supply to the right lung. So we ballooned the blocked stent with the 5 into 10 mm polo balloon to resume the blood across the stent. This is the post-ballooning check angiogram with good flow. This is the MAPCA with discrete narrowing, supplying the middle and the lower lobe, right lobe. This is stent 2.5 into 16 mm axillum stent deployment. This is another MAPCA that is collateral that is supplying the upper right lobe, and it is being stented with the 2.5 into 16 mm axillum stent. But then again, in September, we have to revisit the collaterals and augmented the blood supply through ballooning. This is all we could do for this child to improve the quality of life of this baby. But this child needs definite treatment. That is either recruitment of collaterals, that is unifocalization with VSD closure, or the heart-lung transplant. Unfortunately, neither of them is offered in Pakistan. Then we have another case, Muhammad Bilal, 17 years old, diagnosed at birth with tricuspid atresia, pulmonary atresia, and intact interventricular septum. The palliative procedures that he had undergone are Blalock tossing shunt, BT shunt in November 2006 at 6 months of age, and Grant shunt that was performed in July 2007 at 1 year of age. His clinical status from 2007 to 2023 remained more or less steady with a slow progressive decline in saturation. His current saturation remains in low 60s and drops down to 50s on exertion. He is on intermittent supplemental oxygen therapy. This is his CAT studies that was done in July 2023 that showed good size, confluent PAs with no anatomical distortion, laminar flow in SVC and branch pulmonary arteries, with the PA pressure of 22/19 with the mean of 20 millimeter of mercury. This is the left subclavian angiogram showing huge venovenous collateral rising from the left SVC and draining into the IVC, suggesting high PA pressures. And the second angiogram shows good LV function with the LVDP of 16 millimeter of mercury. So status now, a diagnosis of failing gland shunt was made for the child. Options available: left upper limb palliation with creation of an arteriovenous fistula with limited functional permanence, or BT shunt, the 5 to 6 mm shunt as a final destination therapy. So what next do we have for this child? That is heart-lung transplant. The discussion above brings us to a dead end and makes us think and deliberate on options available to us. The situation emphasizes the pivotal moment where medical professionals must make crucial choices regarding patient care or treatment pathway. The issue stresses the importance of developing a heart-lung transplant program in Pakistan, which is crucial for several reasons. The program would provide a lifeline for patients with end-stage heart and lung diseases who have exhausted other treatment options. A dedicated transplant program would offer hope and a chance and extended life for these patients. Introducing heart-lung transplant in Pakistan is crucial, considering the country's high prevalence of cardiovascular and respiratory diseases. Here is a step-by-step approach to establish a heart-lung transplant program in Pakistan. First one is needs assessment. Evaluate the demand for heart-lung transplants and identify potential candidates. Infrastructure development. Establish a dedicated transplant center with state-of-the-art facilities, ICUs, and operating rooms. Team assembly. Gather a multidisciplinary team of experts, including cardiothoracic surgeons, cardiologists, pulmonologists, anesthesiologists, and nurses with transplant experience. Training and capacity building. Provide training and workshops for the team in heart-lung transplantation, immunosuppression, and post-transplant care. Protocol development. Establish standardized protocol for patient selection, evaluation, and post-transplant management. Organ procurement. Develop a network for organ procurement and distribution, collaborating with the local and international organizations. Public awareness. Educate the public about organ donation and transplantation, addressing cultural and religious concerns. Government support. Collaborate with the government to establish policies, laws, and funding for heart-lung transplantation. International collaboration. Partner with established transplant centers globally by mentorship, training, and sharing best practices. Program initiation. Start the heart-lung transplant program, beginning with a few cases and gradually expanding. The team gains and experience and confidence. By following this structured approach, Pakistan can establish a successful heart-lung transplant program, providing life-saving treatment for patients with advanced heart and lung disease. Join the movement to establish heart-lung transplantation in Pakistan. Together, let's make heart-lung transplantation a reality in Pakistan. Join the movement by sharing this message on social media, contacting your local representatives and healthcare leaders, donating to support the cause, volunteering your time and expertise. Together, let's save lives, improve healthcare outcomes, enhance Pakistan's healthcare reputation, provide hope and quality of life to patients and their families. Let's make a difference together. Thank you.
Thank you very much, Dr. Mamoona. Such a confident presentation. Any question, please? So, I think Dr. Abdul Razak is coming shortly, so I would like to invite Dr. Nida Feroz. She is talking about TGA with regressed LV, surgical outcome following PDA stenting, our experience at AFIC. So, Dr. Nida Feroz from Pediatric Cardiac Surgery Department, AFIC, Rawalpindi.
Bismillahirrahmanirrahim. Assalamu alaikum. Early arterial switch is considered the standard modality of treatment in patients presenting with TGA with an intact ventricular septum. Scarcity of specialized pediatric cardiac services and poor antenatal diagnosis leads to increased number of late presentations of TGA infants with an intact ventricular septum. Late presentation with regressed involuted LV is less common in developed countries. It is a problem of developing countries, and it leads to an additional burden of the requirement of LV retraining by a PA band with a modified BT shunt, and PDA stenting. The cost of multiple surgeries is also a challenge in developing countries like ours. The objective of this study is to share our experience with the early surgical outcomes of arterial switch operations in infants of TGA with an intact ventricular septum who presented with a regressed LV and underwent LV retraining by PDA stenting. It was a retrospective observational study conducted in congenital cardiac department of AFIC. The study duration spans over a period of 3 years from January 2021 to Jan 2024. We included all TGA patients with an intact ventricular septum who had a regressed LV and underwent arterial switch operation after successful LV retraining with PDA stenting. The exclusion criteria was patients of TGA with intact ventricular septum in whom either LV retraining was not achieved after PDA stenting and required surgical retraining, or ended in mortality in the period between PDA stenting and before they could undergo an arterial switch operation, and cases requiring coronary revision per-operatively. We included a total of 29 patients in our study who had undergone PDA stenting for regressed LV and underwent arterial switch after LV retraining. The demographics of our results were the mean age at presentation of these infants was 23 days, whereas at the time of stenting it was 27 days and 47 days at the time these patients underwent an arterial switch operation. 55% of our patients were female, whereas 44.8% were male. The mean weight at presentation in these infants was 2.99 kg, whereas at the time of arterial switch, it was 3 kg. Our mean cardiopulmonary bypass time was 199 minutes, and cross-clamp time was 113 minutes. In terms of LV dimensions, the LV mass index in these patients at stenting was 29.83 grams per meter square, whereas at the time of undergoing an arterial switch operation after successful LV retraining, it was 46 grams per meter square. The LV end diastolic posterior wall thickness at the time of stenting was 3.14 mm, and at the time of switch, it was 4.46 millimeters. The mean duration in our patients for LV retraining between stenting and arterial switch was 20 days. LV function at the time of weaning off bypass was 28%, and after chest closure, it was 34%. The ventilation time was 111 hours, with an ICU stay of 10 days. 78% of our patients were weaned off cardiopulmonary bypass on moderate inotropic support, whereas 22% required high inotropic support. After 48 hours, 22% still remained on high inotropic support, whereas 26% were de-escalated to low inotropic support. In terms of outcome, 72% of our infants survived an arterial switch operation post-LV training in late-presenting TGA with intact ventricular septum. We had a mortality of 27.5%. LV retraining and regressed LV are more commonly encountered in developing countries. In most developed countries, antenatal or early neonatal diagnosis leads to an early arterial switch. That is why most of the studies available to us are also from developing countries. Primary arterial switch in a regressed LV has the downfalls of low cardiac output syndrome, prolonged ventilation, need for ECMO, which precludes it from being the standard treatment adopted. We define a regressed LV as a banana-shaped LV geometry, septal motion with the RV, LV end diastolic posterior wall thickness less than 3.5 mm, and indexed LV mass of less than 35 grams per meter square. Candidates fulfilling any of the above two criteria were considered for LV retraining. The methods for LV retraining include hypoxic or pre-ASO LV retraining, which include PA band with a modified BT shunt, and PDA stenting. Normoxic or post-ASO LV training include pharmacological measures and mechanical circulatory support in the form of ECMO or ventricular assist devices. In patients and in countries like ours, The disadvantage of a surgical LV training by PA band include that it's an invasive procedure with a stormy postoperative course, interstage mortality, and hemodynamic stress caused by PA band is recognized as a cause of late ventricular myocardial dysfunction and progressive neo-aortic regurg. So for our setup, PDS stenting for LV retraining is an affordable, safe, and attractive option where surgical service is limited, lower risk of branch pulmonary complication. However, the risks include failure of LV retraining in the presence of a large ASD, which prevents adequate LV volume overloading, stent occlusion, migration, infection, arrhythmias, and pulmonary overcirculation. This is a study which shows that ductal stenting is a good alternative strategy for left ventricular retraining in TGA with regressed LV, even in patients with occluded ducts. There's another study that advocates that ductal stenting is a less morbid method of left ventricular retraining in TGA with regressed LV. Its major advantages lie in avoiding pulmonary artery distortion and neo-aortic valve regurg resulting from banding, and also in avoiding a thoracotomy. This study also shows that ductal stenting is an effective and attractive method of retraining in an involuted LV in TGA with IVS. However, its efficacy is mitigated by the presence of a large interatrial communication. The limitations of our study were that it was a retrospective study. There was no control or comparison group available to us, and only early post-op mortality and LV dysfunction was taken into account. In conclusion, we can say that ductal stenting is an effective and attractive method of LV retraining in regressed LVs in TGA with intact ventricular septum patients with acceptable post-operative outcomes. Thank you.
Thank you, Dr. Neda Feroz.
I have a question, please.
Yeah, sure.
This is a very good outcome that 20 out of 29, I think so 21 survive after arterial switch.
Yes,
That was your
8.
study showed. Have you did just the PDS stenting or septostomy along with PDS stenting?
Just
Sir,
PDS
it was
stenting.
primarily the PDS stenting because we wanted to maintain the preload for the left ventricle. So we avoided septostomy. Just a 4 to 5 millimeter of PFO would suffice, and of course the SATs did improve, and the LV got good volume to preload, and this was our aim.
And how much time you did after stenting?
Sir,
your
it varied.
operation?
So at least we gave 2 weeks time, and maximum we went to 40 days. Again, since we don't...
Our mean was around 20 days,
20 days.
for LV retraining.
Okay, after 20 years. I just want to add a comment on that. Basically, in TGA intact septum, it's a complex morphology.
Yeah.
And in my experience, what I seen that even LV regress within 2 or 3 days of life. And that's why whatever we do, the volume load, even they have a patent duct, I'm telling about my experience. LV regress, whatever is the reason, and we have a great experience of arterial switch in the Children's Hospital, Lahore, but you have a very bad prognosis picture. But that's incredible, and you did a great job. And this, I think so, you need publication for such a good amount of patients that you did.
Thank you.
Excuse me.
Please.
Dr. Saab,
Please ask your question.
just one quick question. You included only the patient who had PDS stenting and then successfully retrained and then ASO.
Venti.
Do you have any idea what about those patients who had PDS stenting but their LV was not trained? What happened with that group? Did we offer the PA band in them or?
Yes,
We did offer PA band to some of those patients. I did mention that we excluded the patients who needed surgical LV retraining
No,
from
I
our
mean,
study.
just number-wise, roughly?
I don't have a clear idea at the moment.
We had 2 patients who had inadequate LV training, so we put them on the other.
Only 2.
Thank you. Any other question, please? Okay. Thank you, madam. So now I would like to invite Dr. Abdur Razak Mughal. He is head of Department Pediatric Cardiology at Faisalabad Institute of Cardiology, and he is Dean Children's Hospital, Faisalabad. Dr. Abdur Razak Mughal will talk on device selection and sizing for transcatheter closure of VSTs, a guide for interventional cardiologist. Aye, sir.
Bismillah ar-Rahman ar-Rahim. Thank you very much, dear organizer, and especially Brigadier Khurram and Brigadier Amjad, all the team of AFIC. The topic was assigned is device selection and sizing of transcatheter closure of VST. Before going into the detail, we have to go for basic insights that the isolated VST is the commonest congenital heart disease, with 80% of the VSTs are perimembranous, rest are the less common. Before going to device closure of any VST, we should be well aware of the morphology of the VST. What is the location and size of the defect, margins of the defect, what is the relation of AV and VA junction, relationship to the conduction tissue, shape of the defect from both sides, that from left ventricle side and right ventricle side, there are multiple defects, and we should also consider for the spontaneous closure of the VST. I think videos have to change. Before going to device closure, we have to go for echocardiography of the patients. And you know, the defect can be at perimembranous septum and can have a gerboard-like shunt resulting in tricuspid regurgitation. It can be a muscular defect, and that can be a doubly committed. Again, sorry for the videos, I corrected there, but that can be perimembranous, and that can be very close to the right cornicus. When a VST should be closed, all of you are well aware of the VST indications, that a symptomatic patient which is not responsive to medications and significant left-right shunt, at least QPQS 1.5:1, is failure to thrive and having significant left ventricle dilatation. Some of the expanded indications which can be considered are development of mild mid-cavity RVOT gradient or obstruction, then development of subaortic ridge but no LVOT obstruction. In this scenario, you can also go for the device closure. Then the outlet type of VST, even when small, because there is a propensity for development of right cornicus prolapse. And in residual VSTs of the post-surgical patients, this can be attempted. The device closure was first attempted by, described by Locke et al. In 1988. And since then, multiple defects have been closed by the devices like congenital, post-infarct, and post-surgical patients. The eligibility criteria is at least weight should be 8 kg and left to right shunt with a QPQS ratio is 1.5:1. The routes can be venous or arterial or both. Venous side depends upon the location of the defect. For mid-muscular VST, apical muscular, usually we use internal jugular vein route. For perimembranous and anterior muscular VSTs, femoral venous approach is usually used. So different techniques for closure of the VST are antegrade, retrograde, hybrid, and transeptal antegrade. In antegrade approach, this is the closure of the VST from venous side. Traditionally, this was initially adopted, and crossing was from right side, then from left side, and then snaring the wire and making an AV loop. It was a very complex procedure and time-taking, and patient usually undergo hemodynamic compromise. Then is the retrograde approach that is more feasible. Recently, we are doing through retrograde approach, and that is from arterial side. It is a relatively faster technique and technically less challenging. Few of the centers are going for hybrid closure of the VST, and that is a perventricular without going in the cardiopulmonary bypass. And in few centers I have seen, and in one center I have assisted this case. Device selection, the type of the device is based on basically ventricle septal aneurysm, length of the subaortic rim, VST diameter. The device chosen to be 1 to 2 millimeter greater than the largest measurement on transesophageal echo. In perimembranous VST device selection, membranous septal aneurysm should be looked, it is whether present or not. It's what is the distance of this defect to the aortic valve, how much close it is to the tricuspid valve, what is the size of the defect, it is large, small, or moderate size. Then different devices should be in your mind, like ADU1, ADU2, PFM coils, symmetric or asymmetric VST devices. What is the best device for the perimembranous VST? Device should be optimal, having optimal radial force with less clamp force, low profile with high occlusion rate. It should be having stability and flexibility. It should have basically the ability to be deployed from antegradally and retrogradely. Delivery system should be flexible, having flexible cable and sheath, and which allows the device to coaxially align with the interventricular septum. As you know, previously available devices were traditionally Rashkin umbrella device that was having a large delivery sheath, and that was a very complex procedure, and there was a lot of difficulty to reposition and deploy the device. Then there were a lot of cases of complete heart block. So modification of the device came with one disc relatively shorter, modified from towards from the aortic cusp end, and sometimes tapered end. This is a knit occluder device. We haven't used this, but a colleague have shared this, and it is being used all over the world. It's a double-layer coil tamponates the vascular VST passage. It has an inner and outer layer. It has a reverse winding of the outer layer add-on to the inner layer. The two sizes are available, basically 6 millimeter and 6 and 8 millimeter. And it is more basically feasible for those cases where right cornicus prolapse is there. So you can see there is an initial angiogram, there is right cornicus prolapse. This device is, the device was selected 6 millimeter of diameter. The device was deployed in the ascending aorta and then taken into the defect, and then right ventricle disc was released, and it showed that it has a good result without any causing aortic valve regurgitation. This device can be repositioned and supports and avoids progress of right cornicus prolapse. However, resolutions can be there. Then there are different devices like ADO2, ADO1, which is a traditionally device which was being used for PDA. But we use this device, but again, we have to take AV loops, and there was a lot of difficulty to deploy the device. The aortic room should be more than 3 millimeter because LV disc is a relatively larger one, and this is used in more like tunnel-shaped defects and having enough space from the tricuspid valve. Then is a double disc device. We are currently using these devices. There are different varieties of the devices like cocoon devices, MFR devices. They are good for perimembranous VST with aortic rim 2 millimeter. These are suitable for window, tunnel, and aneurysmal type of the VSTs. The problem is less with these devices. We haven't seen any complete heart block in our patients. We have done 40 cases of MF devices, and neither was embolized. The cocoon double disc device and MFR devices have basically been used by us in our cath lab. This is a 4-year-old baby having high muscular VST. That was a tunnel shape, and you can see the device. We basically measured the defect that was 4 millimeter, and we took the cocoon device of 6 millimeter, and that was antegradally deployed. We crossed the from the left ventricle side and loaded the device, and that was successfully deployed. And there was no basically aortic valve regurgitation or any problem to the tricuspid valve. MFA device is a self-expanding double-disc device. It's constructed using nitinol wires. It has different shapes on each side, connected with a cone-shaped waist, which is a flexible radial having radial strength which is low. Design aims to reduce risk of conduction problems, and that can be screwed from both sides. That is, can be deployed from the right ventricle side and as well as left ventricle side. Different sizes are available from 5.3 to 14.12 millimeter. This is a muscular VST which was basically closed by us in the cath lab by using MF4 device. Again, the technique we used was anti-gradely. We crossed the defect and had basically closed the defect from the right ventricle side. That you can see the device had a good position and there was no residual leak through the device. Again, this is one muscular VST device that was approached retrogradely, and basically we had we closed with basically without use of a transesophageal echo, and it was done by transthoracic echocardiography. So different techniques have plugs have also been used. We haven't used such plug in our cath lab. Then there are different low-profile devices like ADU2 device and Picola device. Picola device is for small babies like infants, and it's coming into the Pakistan market. Then it's muscular VST device. It is the speeded aortic rim should be more than 4.5 millimeter. The device waist is chosen according to the left ventricle entry diameter without any need to oversize. So this was done from left ventricle side. We crossed the defect from the left ventricle side, snare from in the pulmonary artery, and then we basically deployed the device. The device size was 14 millimeter. The main issues in the outcome is basically the heart blocks, that is the AV blocks. Traditionally, in traditional devices initially were used, it was a very common problem, but nowadays it is less problem. Aortic valve is the main issue from where you basically cross, whether there is aortic valve regurgitation or not. Then you have to look for tricuspid valve during deployment, whether there is any tricuspid valve regurgitation or not. Any residual shunt and in post device cases like hemolysis should be observed, and any right ventricle or left ventricle outlet obstruction. No ideal device, no ideal patient. You have seen we have done different devices in different type of VSCs. Different morphologies can bring different results. Different devices can bring different techniques, can bring different results. If you can prove that the procedure is not really difficult and safe, the indication will be opened. Recent devices have improved the outcome of the procedure. Thank you.
Thank you, Dr. Any question, please? Mike Deng.
I have very innocent question. We are a resource limited setup. Have you used AST device in muscular VST? Any of you?
We have used an AST device.
Any problem with that or any particular point?
We did a perventricular closure VSD where we used Amplanzer AST device for that. Initially, we thought that we might end up into a problem. The thing about VSD device closure is that, as Razak has told you, that it should have good clamp force, it should have a good radial force rather than a good clamp force. So we are still not very happy with using an ASD device in place of it. But we were afraid that having to choose a smaller VSD device would lead to embolization. But then after some few days later, once we had deployed that ASD device, we found that it was very neatly fixed with the septal wall. And we did not have any problems with, like it was not abutting and there was space between the right disc or left disc and the septal wall. So we had a good result with that. It all depends on what kind of a substrate you are dealing with and how safely you can do the procedure.
Basically, it's all the interventionist depends upon, because when we talk about the VSDs, it's not only the VSD, it's the site, it's the complications, it's the pulmonary hypertensions, and also the leaking of the valve. Therefore, the selection of device, whether you do with VSD or ASD device, it's all dependent, and especially for the neonate, if you have a mid-muscular and try to cutaneous, then it's better to do the ASD because it's the softer device and complication rate is less.
ASD device is a very bulky device. You know, have large bore discs from the waist diameter. So in neonates, how it basically, I have comment because
yeah, I have an experience of doing two cases. One we did with per ventricle. That case went very well. But another case we did where we placed in an ASD device and we ended up with creating a lot of tricuspid regurgitation. So we were not happy with the right side disc affecting the tricuspid valve. We had to explant it and ask the surgeon to close. So yes, when you're putting in these devices, you should be cognizant of the AV valves, the aortic valves, the bundles that are going through that area, and the damage that you can cause. So without, it's actually your choice there, your decision at that time, whether you want an embolized device or you want a device still in its place. But then it has costs.
And the last thing is ASD device is used in ischemic VSRs. So I would like to invite Madam Sadia Ilyas. We are thankful, Madam, you have come from Peshawar. She is talking about anatomy and imaging of atrial septal defects, implications for transcatheter closure. I would request to be in time, please.
Sir, just to answer your question, we are regularly using ASD devices and post-infarct VSR, as Sir just mentioned, for all those which are larger than 18 mm. So today my talk is basically on atrial septal defect imaging and percutaneous closure, and I've tried to keep in view the adult, in adult perspective. How would you change the slides? Yes. Okay, so adults, ASD, it's the most common congenital lesion after bicuspid aortic valve in adults, and that is accounting for about 30 to 40% of those with intracardiac shunt lesions in adults, and they are usually asymptomatic. PFO, I'm mentioning PFO because we usually confuse the two, but there is some difference. Usually they remain quiet until there is a reason that the pressure is actually higher to cause a shunt. And it's not actually considered a true ASD, but we are just taking it in the same group because they function the same. So this is just to show you what a PFO is. And the clinical syndromes that are associated with ASD and PFO, they are extremely variable, and they represent a significant health burden on pediatric, adult cardiology, neurology, and surgery. So what is the pathophysiology of ASD? There is left to right shunting, and the defect, it depends on the size of the defect, the relative compliance of the left ventricle and right ventricle, the vascular resistance of both the circulations. Why do the symptoms worsen with age? We have seen that there is increased left to right shunting with age due to increase in the left versus right ventricular end diastolic pressures. There is development of systemic hypertension. There are other acquired heart diseases that lead to increased left ventricular end diastolic and or left atrial pressures. So what are the potential complications of undetected ASD? You can get all sorts of complications if the ASD is untreated or undetected. And these are certain types of ASD. The sinus venosus, superior sinus venosus ASD, and the secundum ASD. These are now amenable to device closures, whereas the others go to the surgeons. These are just a quick go through the guidelines, and we can see that RV volume overload is a must. And then we realize and check for the pulmonary hypertension. We check if there is any symptoms like paradoxical embolism. And for those patients who have high pulmonary artery hypertension pressures, and they do respond to the pulmonary vasodilators, we opt for fenestrated closures, leaving a pop-off valve there. So what are the indications of ASD closure? Obviously, right cardiac enlargement, paradoxical embolism, exercise-related cyanosis or orthodoxia pleitopnea syndrome, left to right shunt with pulmonary hypertension, which is responsive to the vasodilators, or they tolerate the balloon occlusion test. What are the contraindications? Obviously, a recent or inactive infection, a thrombus, Eisenmenger, or any contraindication to antiplatelet therapy, because in device closure, we give that for 6 months. So I have classified the ASDs according to the device closures into ideal ASD, a complex ASD, and those which are excluded. So ideal ASD is basically a small to moderate defect, which is central, has normal anatomy, there has no other congenital heart disease associated, and absent pulmonary hypertension. Whereas the complex ASD, there is
recording in progress.
Rim deficiency, malign septum, malaligned septum, multifenestrated, aneurysmal septum, prominent eustachian valve, larger size, severe pulmonary stenosis, and reversible pulmonary hypertension. So these we do attempt device closure, but we consider them slightly more complex. They are not very straightforward. And those we exclude from device closures are those which are very large, they are deficient IVC rim, the ostium primum, inferior sinus venosus, coronary sinus defects, and pulmonary hypertension with high PVR. Now coming to the imaging. Obviously, we have a few modalities commonly using transthoracic and transesophageal echo. I'm not aware if any center in Pakistan is using intracardiac echo. We do have 3-dimensional transesophageal echo available. And this is just an example of percutaneous ASD closure. I'll just quickly go through. These are certain views that we take. And these are very easily taken in young children because of good visualization of the subcostal views. And you can see the transthoracic views, the different rims that we take and measure. This is how a PFO looks like on a transesophageal echo. Then we have the 3D echo reconstruction, which is obviously better, and it gives us more detailed information, and the eyes. So these are some of the views taken in eyes. Now, just to discuss the different advantages and disadvantages of these modalities, transthoracic, obviously low cost, easily available. You can take all planes in it. But the disadvantage is that sometimes the view is not very good. Image quality isn't good in elderly or obese patients. And if we do the ASD device closure on transthoracic echo, we cannot see the lower rim of intraatrial septum after closure, after device placement. Transesophageal echo, obviously it is improved quality over transthoracic. We can have 3D echoing in it, but this requires sedation and there are risks of arrhythmias and damage. Now coming to the eyes, Obviously, it is very good. We get intracardiac views, but it is not very feasible in young children because you need 8 to 10 French sheath. It's extremely expensive. It's a single-use catheter. And obviously, the operator has to do 2 tasks at the same time. So with 2 hands doing both the procedure and doing the interventions is not easy. What do we see on these imaging? We look at all the rims. And these are some of the rims that we look at during our imaging. And we look for the shunt. We look for other associated findings. We look for the presence or absence of atrial septal aneurysm. We look for the pulmonary veins. This is just a view of Sir Shakil Qureshi talking about sinus venosus ASD per catheter closure. He's one of the pioneers. And we can see that those are amenable to device, the CP stent closure by percutaneously, which have pulmonary veins opening below. And the last picture, I'm not sure if I have a pointer. If these are way above, then obviously the CP stent would cause pulmonary stenosis, and these are not recommended for percutaneous closure. Then coming to multifenestrated, initially, previously they were being sent to surgeons. Now we have newer devices with narrower waist. We are using them at Lady Reading Hospital, and they just help in closing. And you can see that there is a very thin waist, narrow waist here as compared to the broader one used for the bigger ASD defects. We have published our data of our initial experience with the Implanzer cribriform devices. Now, coming to the complications, obviously complications are cardiac perforation, device embolization, bleeding, pulmonary embolism, device erosion, device fracture, infective endocarditis. And here I would like to highlight the device erosion is most commonly occurring in the first 72 hours, but it can occur up to 6 years. So we do need to follow up these patients for very, very long time, especially after putting an atrial septal occluder in the implant. So what is the future? The world is now moving towards non-fluoroscopic device closures, without fluoroscopy, without angio, because it is for our limited resource setup where we have shortage of cath labs and we have infection in our hospitals. This seems to be the future. This can be easily done in the community, and transthoracic echo is non-invasive and it has less side effects. So that is how I was fortunate enough to attend this workshop. And you can see that they're actually doing this transthoracically. The child is not under GA, it's just sedation. And they are doing percutaneous ASD closure in a child on transthoracic echo guided only, without the use of fluoroscopy. And obviously we were not wearing any lead. So we can see that they are actually monitoring the catheter as it's crossing the IVC, and then they are measuring the catheter over the... So this was the workshop, and I had the honor to learn directly from Dr. Pan visiting from China. Thank you very much.
Thank you, Dr. Sadia. We have no time for questions. Now, I would like to invite Dr. S.N. Beg from Multan. He would be talking about stenting of coarctation of aorta, double balloon technique. Dr. S.N. Beg.
इसका बेटा पॉइंटर कौन सा है ये चल ठीक Bismillahirrahmanirrahim. Thank you very much, AFSC team, especially Brigadier Amjad and Brigadier Khurram. This morning I would talk about the double balloon technique for coarctation stenting. Coarctation is a common congenital heart disease. It is about 6 to 8% of all the congenital heart defects. Diagnosis is made by transthoracic echocardiography, and sometimes we do CT angio or conventional angio to see the suitability and measurements. In adults, it's present with hypertension, headaches, intermittent claudication, and sometimes asymptomatic. In the usual coarctation of aorta, the site of the coarctation is distal to the left subclavian artery, but rarely the coarctation site is just close to the origin of the left subclavian artery. This is the CT angiogram for the same. We used CP stent in this technique of double balloon, which is balloon expandable and MRI compatible. It has a PTFE covering, which is either pre-mounted or is hand crimped. Its long-term results are described elsewhere in COAST 1 and COAST 2 trials. This is the conventional technique where the origin is far from the coarctation site, aortogram done, and then measurements are done. After crossing with the glide wire and MP catheter, a stiff wire is part in the ascending aorta, and over the stiff wire, the long sheath is taken. Afterwards, the balloon and the stent assembly is taken and positioned across the coarctation site, and the balloons are inflated, and the final results are shown here. This is the conventional technique. Now the double balloon technique, the angiogram is done after crossing, measurements are taken. We used Osipka balloons. 2 balloons are taken according to the measurements, and they are prepared over 2 wires. Each wire is passed from each balloon, and one wire is passed in the ascending aorta, and other one is part in the left subclavian artery. Here you can see the wires are being packed. Now the balloon is, the 2 balloons and the stent is taken and is positioned across the coarctation site. You can see a needle placed here. It is a needle. Instead of placing a marker via left arm, we are using this shortcut and placing a needle over the body of the patient. Check angiograms are done to see the position, and the 2 balloons are inflated simultaneously by 2 operators under pacing. Afterwards, another balloon is taken and it is placed at the distal end of the stent in order to flare the distal end. Check angiograms are done, and you can see a nice flow to the left subclavian artery. Pullback gradients are recorded, and integrity of the femoral arteries are checked. So far we have done 5 cases ranging from 16 years to 39 years, and pre-gradients were almost above 40 millimeter of mercury, and they fell to reduce to less than 10 millimeter of mercury. All of them had a very nice left subclavian artery flow. One patient developed acute limb ischemia, which was treated by embolectomy. Now another interventional cardiologist, Dr. Botera from Milan, Italy, he described another technique. He took a needle and passed through it through the stent. Through this needle, he created a hole in the covering and passed a wire through this opening. You can see the wire is passed. This wire which was passed through this hole is parked in the left subclavian artery. Afterwards, when the stent was placed, a balloon was taken over this opening and it was inflated to preserve the flow to the left subclavian artery. I would conclude that double balloon technique is safe and effective in coarctation stenting when we need to spare the flow to the left subclavian artery. Thank you very much.
Thank you.
I saved your time.
Thank you so much. I would request my EP team to give us few more minutes. I think this is the last talk. Now I would like to invite Dr. Anusha Aziz. She is from Cardiac Rehab Department. She is working at Armed Forces Institute of Cardiology. This is the last talk. Display.
Thank you.
इसी से डायरेक्ट चलिए आप.
Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Anusha Aziz from AFIC, and I'm here to represent the topic that is cardiac rehabilitation in post-operative pediatric cardiac population. So, there are different types of surgeries which are performed for the repair of the congenital heart diseases. And these repairs could be closed heart procedures and could be through the open heart procedures. And we have to talk about RACs as well. Now, what is RACs? RACs is basically risk adjustment congenital heart surgeries. In RACs, we talk about the categories. The heart surgeries are further classified into different categories. And more complex the procedure is, more focus on the rehabilitation is needed. There is a graph which shows the distribution according to the nomenclature of the procedure proposed by Aristotle's score, and the graph shows the variability of treated patients between surgical cases. You can see on the graph that ASD surgical repair is 9%, PDA closure surgical repair is 8%, and verticulotomy is 4%, shunt central is 3%, AVSD repair is 3%, coction repair is 3%, aortic stenosis repair is 2%, and VSD repair is 2%. So all of these repairs have been shown in this graph. Now let's see what's the rehabilitation. So rehabilitation has been defined by CSP, which is Chartered Society of Physiotherapy. So physiotherapy rehabilitation aims to optimize patient function and well-being to help integrate the patient back to their chosen lifestyle activities, whether at home, at work, or leisure. There is some difference between acute care and rehabilitation as we are talking about the post-operative cases. So acute care is performed right away after the procedure, and it is mainly focused on individual survival. And when we talk about the rehabilitation, which is performed on the later stages, it relates to the education and training of individuals so that they can live independent lives by focusing on the promotion of self-care and functional independence. Here, a point to be noted is that the population we are focusing is the pediatric population. So we have to educate not only the patients, but their families as well. And the phases of rehabilitation are further classified into two parts, that is phase 1 and phase 2. Phase 1 is further classified into two subdivisions, same for the phase 2. When we talk about phase 1, it includes acute medical care, inpatient rehabilitation, and phase 2 includes the home program and outpatient rehabilitation. In the acute medical care, we focus on the decrease of functional impact and the facilitation of the transition to home. Inpatient rehabilitation also includes the functional and the therapy needs and improve functional and facilitate transition to home. So our main focus is basically the patient's transition to home. Next is a home program, which includes the maintenance of the facilitation which we already have provided and the education of patient and their families. Along with that, outpatient rehabilitation includes improved function and risk factor management. When we talk about phase 1, it includes early assessment and recognition of the following, which includes neurological, vocal, feeding, and motor abilities. So as a physical therapist in the ward, post-operatively, we have to focus on all these things, and then we make the plan accordingly. This is followed by the rehabilitation interventions. For the rehabilitation intervention, physical and occupational therapy is performed, the main aims of which are to maximize the functional mobility. Now we know that the functional mobility means that patient is able to move freely in its atmosphere. Now atmosphere could be home or the school of the patient or anywhere else. Okay. Next is the minimizing the deleterious effects of the bed rest. We know that the muscles move towards the atrophy when there is prolonged bed rest, and we have to prevent the deconditioning as well. As a physical therapist, it is our main focus. Then next thing is assess and facilitate achievement of developmental milestones. Again, our population is the pediatric population, so we have to focus on the developmental milestones as well. And we have to provide appropriate recommendation for follow-ups. In the AFIC, our main focus is, as we are talking about post-operative cardiac patients, pediatric population, so our main focus is on the respiratory rehabilitation. In the respiratory rehabilitation, we care during artificial ventilation. Some patients are on ventilators, so we have to take care of their clear chest and clear airways. For that, we have to monitor the oxygen saturation. We have to do periodic endotracheal tube suctioning. And along with that, we do the chest therapy, which includes the vibration, shaking, and percussion. It depends on the lobes of the lung, that which lobe is more affected. And some patients also have chest drains, so we have to do the milking of the chest drain to clear their chest. This is the standard or general procedure which is followed to clear the particular lobes of the lungs, but as our patients have the central incision in the chest, so we do it according to their incision. We don't have to affect their wound. Now, outpatient rehabilitation program is the phase 2. Phase 2 is to be initiated by the patient after the certain period of cardiac surgery. Now, there is a Canadian study who shows that the children with congenital heart diseases often have inactive lifestyle and motor deficits beginning in infancy. And the least active infants continue to be the least active children at school as well. So we have to focus to improve their motor skills, to their ability and ability to move, and to make them more active participant in the life. Now, stages of rehabilitation includes 5 phases. Phase 1 is to control pain and swelling. Phase 2 is to improve range of motion and flexibility, for which we have to perform passive range of motion initially, and then we will move on to the active range of motions. Phase 3 is to improve strength and begin proprioception and balance training, because such kind of children oftenly face the balance problems. The phase 4 is proprioception, balance training, and sport-specific training. One thing is that patient is able to move in the proper gait. But next thing is if our patient is capable of playing particular sport or participating in such sports, so we have to focus on that as well. Then there is a 5 phase, which is gradual return of full activity. So conclusion is that cardiac rehabilitation in post-operative children with congenital heart disease has a vital role in returning them to full activity and preventing sedentary lifestyle. Rehabilitation services needed to be improved in Pakistan according to international standards. Thank you.
Thank you, Dr. Nusha, and it's okay. Now, I just dedicate my talk to EP department. Thank you very much. Now we conclude our session. Any question, please, from pediatric cardiology department? Okay.
First of all, this is not pediatric, this is a congenital defect expertise. Na? So the misconcept regarding the pediatric, congenital heart is always symptomatic and hemodynamic dependent. It may appear at 2 days of life or maybe at the 75 or 80 year of life. Thank you.
Thank you very much, Brigadier Shabir, sir. Now you can take over the session. Thank you so much for bearing us out.